Balloon tamponade. To control hemorrhage in certain patients, balloon tamponade may be used in esophageal varices. In this procedure, pressure is exerted on the cardiac, that is upper orifice of the stomach, and against the bleeding varices by a double balloon tamponade, that is sense taken Blackmore tube. The has four openings, each with a specific purpose: gastric aspiration, esophageal aspiration, inflation of a gastric balloon, and inflation of a esophageal balloon. The balloon in the stomach is inflated with 100 to 200 ml of air. An X-ray confirms proper positioning of the gastric balloon. Then the tube is pulled gently to exert a force against a gastric cardia. Traction may be applied with a weights of by attachment to a football helmet. Irrigation of the tubing is performed to detect bleeding. If returns are clear, the esophageal balloon is not inflated. If bleeding continues, the esophageal balloon is inflated. The desired pressure in the esophageal and gastric balloons is 25 to 40 mm of mercury as measured by the manometer. There is possibility of injury or rupture of the esophagus with inflation of the esophageal balloon, so constant nursing surveillance is necessary. Gastric suction is provided by connecting the gastric catheter outlet to suction. The tubing is irrigated hourly and drainage will indicate whether bleeding has been controlled. Room temperature lavage or irrigation may be used in the gastric balloon. The pressure within the esophageal balloon is measured and recorded every 2 to 4 hours via the manometer to detect underinflation or overinflation with potential for esophageal injury. When it appears that bleeding has stopped, the balloons are carefully and sequentially deflated. The esophageal balloon is deflated first and the patient is monitored for recurrent bleeding. After several hours without bleeding, the gastric balloon may be deflated safely. If there is still no bleeding, the tamponade tube is removed. The therapy is used for a short time as possible to control bleeding, while emergency treatment is completed and definite therapies are instituted. It is no longer than 24 hours. Although balloon tamponade has been fairly successful, there are some inherent dangers. Displacement of the tube and the inflated balloon into the oropharynx can cause life-threatening obstruction of the airway and asphyxiation. This may occur if the patient pulls on the tube because of confusion or discomfort. It may also result from rupture of the gastric balloon, allowing the esophageal balloon to move into the oropharynx. Sudden rupture of the balloon causes airway obstruction and aspiration of gastric contents into the lungs. The tube is rested before insertion to minimize the risk. Aspiration of blood and secretions into the lungs is frequently associated with balloon tamponade, especially in the stuporous or comatose patient. Endotracheal intubation before insertion of the tube protects the airway and minimizes the risk of aspiration. Ulceration and necrosis of the nose, the mucosa of the stomach, or the esophagus may occur if the tube is left in place or inflated too long or with too high pressure. The patient being treated with balloon tamponade must never be left alone because of the risk for serious complications. The patient must be monitored closely and continuously. Precautions must be taken to ensure that the patient does not pull or inadvertently displace the tube. These potential complications necessitate intensive and expert care. A confused or restless patient with this tube in place and balloons inflated requires close monitoring to prevent its displacement. Nursing measures include frequent mouth and nasal care. For secretions that accumulate in the mouth, tissues should be within easy reach of the patient. Oral suction may be necessary to remove the oral secretions because of the many potential complications. Balloon tamponade tubes are used only as a temporary measure. The patient with esophageal hemorrhage is usually extremely anxious and frightened. Knowing that the nurse is nearby and will respond immediately can help alleviate some of the anxiety. The tube insertion is uncomfortable and never pleasant. Explanations during the procedure and while the tube is in place may be reassuring the patient. Although the use of balloon tamponade stops the bleeding in 90% of patients, bleeding recurs in 60 to 75%, necessitating other treatment modalities. Example, sclerotherapy and banding. Once the balloons are deflated or the tube is removed, the patient must be assessed frequently because of high risk for recurrent bleeding. Thank you.